on the menstrual cycle from the point of view of bleeding and volume and frequency of bleeding, about regularity of cycle. I'm not going to talk so much about, if you were to look at sort of physiology of menstruation from a fertility point of view, you talk about ovulation, you talk about like, the follicular sort of formation and things like that. That's not what we're really interested in today. We're going to talk about what helps onset of menstruation, what determines when menstruation stops, and how the endometrium sort of generates through the menstrual cycle. We're then going to try and build the pillars of this building, which is understanding the terminology. And the reason why we are understanding the terminology is because this is how, in the past, primarily in the past, menstrual disorders have been sort of described. And there are a lot of terminology. We commonly know menorrhagia, we know oligomenorrhea and maybe polymenorrhea, but there are lots more that we can talk through. As far as FIGO is concerned, they really want us to move away from using these terminologies, and they just want us to call it abnormal uterine bleeding and describe the bleeding as heavy menstrual bleeding, if that's what we want. If we want to say menorrhagia, we just use the word heavy menstrual bleeding. But it's worth us understanding the terminology anyway, because if we were to read through papers, if we don't understand what these terms mean, and it's just a way for us to communicate what's going on. So we will talk about the terminology. But hand in hand with the terminology, we need to understand the pathophysiology behind why menstruation is abnormal sometimes. We can't sort of like replace the understanding the pathophysiology without understanding terminology, because they're not quite sort of overlapping. They sort of sit next to each other, and they're sort of like, there is a bit of overlap, but you need to understand both of these entities separately in order for you to move on to the next part of building this structure, which is understanding diagnostics and then finally understanding management. All right, so this is what we're going to do for the rest of this afternoon. Is everybody with me so far before I launch into my explanation about physiology?
Yeah.
All right, so I'm sure this is not something that is new. I'm sure you've seen this sort of representation of the menstrual cycle in this way, which is the hypothalamus pituitary ovarian axis on the left, and you've got sort of like what happens to each of the hormones during the menstrual cycle, and what is the response of the endometrium. So I'm going to talk you through the bits that are relevant with regards to the talk that we're going with regards to this topic. All right. So when you look at the menstrual cycle, the first half of the menstrual cycle is called a proliferative phase, all right, or the follicular phase. And the second half of the menstrual cycle is called the secretory phase or the luteal phase. Okay. Generally, in a cycle, the average cycle of 28 days, you say 14 days of proliferative phase and 14 days of secretory phase. Now, does anybody want to tell me which half of the cycle is actually fixed? Which half does not deviate away from 14 days? Sorry?
Secretory.
Secretory phase. And why is that?
Because the lifespan of the corpuscle in the state.
Yes, correct. So no matter what your length of the cycle is, and when you have sort of like really long cycles, you know that if ovulation has taken place, that the secretory phase is going to be fixed at 14 days. All right. So if you have a really long cycle and we confirm that it's an ovulatory cycle, we know that the bit that is prolonged is actually the proliferative phase. All right. And that's important to understand because that helps us differentiate the type of treatment we need to use for different people. So if the problem is that there is no ovulation, and that's why the patient of us is having really long cycles, then what we do in order to help them will be very different to somebody who's having ovulatory cycles, but long sort of like a long menstrual cycle. All right. Now, what happens during the proliferative phase is that you've got pulsatile GnRH secretion, which again gives rise to pulsatile FSH-LH secretion. And in the first half of the cycle, you've got this rising estrogen, and predominantly the first half of the cycle is under estrogen influence. and it causes your endometrium. So as you can see, the arteries in the endometrium are generally a bit more sort of, they're not as tortuous as in the secretory phase. The glands are a bit longer, and essentially the thickness of the endometrium increases to about 0.5 millimeters. Sorry, 5 millimeters. All right. Then what happens? Ovulation happens, and whatever is remaining in the ovary becomes the corpus luteum. The corpus luteum, if there is no pregnancy, so if we don't get the support of HCG to keep the corpus luteum going, at the end of sort of like 14 days, that's a lifespan, and it stops producing progesterone. Okay, so what happens then is that it triggers menstruation by the reduction in the steroid production from the corpus luteum, reduction in the progesterone production from the corpus luteum, and an increase in the endometrium. This causes the endometrium to produce more prostaglandins, and that is what triggers off menstruation. It causes the uterus to start sort of contracting, which is why you have dysmenorrhea, and then it causes the shedding of the lining. And once that menstruation has started, in about sort of 2 days of onset of bleeding, you then have it kickstarts, because you have low progesterone and low estrogen, it kickstarts a positive effect on the hypothalamus and the anterior pituitary, and then you have your FSH and LH go up again, and then it starts the proliferative sort of regeneration of the endometrium. Is that clear?
Yes.
Yeah. Okay. So I'm going to move on. So what does normal menstruation mean? So we're talking about a range of 21 to 35 days. What does normal mean menstrual blood loss? It's about 30 to 80 mils. And normal duration is a range of between 3 to 7 days of bleeding. Okay. So when a patient is in front of you, how will you determine if somebody has got abnormal or normal menstruation?
Only really the cycle length and the duration. Maybe people might not estimate exactly the volume of blood that they're losing, but maybe they can tell you about the amount of pads, how much they're soaked.
So there are 3 things you need to determine when you're questioning a patient about their menstruation. You need to determine what their average cycle length is, which is, I think, easy enough to determine. So you just ask them, how long is your cycle? Do you get it every 28 days or 30 days or whatever it is? So you can determine whether there is cycle regularity quite easily with just history taking. Correct?
Yeah.
You can determine duration of bleeding, again, quite easily with history taking, because you can ask them if they, how many days do you bleed? And they will tell you a number, and that will either fit within normality or it won't. So again, very easy. Now, the problem comes is when you have to determine whether there is excessive bleeding or not. Okay, and this is a problem that lots of people apparently have thought about, because I found loads of papers about it. But I'm going to talk you through what was impractical ways to go about it, and then what actually we need to be doing. Okay, so obviously the researchers are really impractical. So they started doing things like spectrophotometric, methods to analyze the pads, to work out how much of hemoglobin content is in the pad. They use radioisotopic methods. And then they decided that just is not going to work, because obviously then you have to, collect pads from a patient, and then it's all good, well and good for research, but it's not going to work in the real world. So then they tried to do something like indirect calculation of the weight by measuring the weight of the sanitary towels, like the way we do on labor ward for postpartum hemorrhage. The problem with that is that menstrual blood is actually mixed with a lot of fluid. It's not just blood. So therefore, it is already inaccurate to begin with. Like, weight of the pad is already going to be inaccurate. All right. And also, the other problem is that the pad itself is not a standardized pad that everybody uses. People buy different sort of like brands, and the absorption capabilities are different. So it was not, again, it was not the most practical way to measure blood loss. So all of this just remained within the world of research, never made it into practical sort of like day-to-day clinical work. So what helps us determine if somebody is bleeding excessively or not? What have you guys used in your sort of clinical practices to decide whether this is heavy menstrual bleeding or not?
I think Snicked Online wants to make a comment.
Sorry?
There's a question online, Aditi.
Oh, hang on. Let's have a look.
Oh, no, I was trying to answer the question you asked, Aditi. It was not
Oh, yes,
a
go on.
question
Yeah,
to
yeah,
you.
tell me.
So one of the things that I've used in gynae clinics is to sort of understand the impact the bleeding has made on the women's quality of life, because I think women come in all different sizes and shapes, and I think instead of trying to quantify blood loss, because 80 mils can be too much for somebody, too little for somebody, so trying to understand whether it's made them take time off of work, whether they needed to take sick days, whether they've actually been symptomatic for anemia sort of helps understand blood loss better.
Absolutely right. So one thing that we can do, and I think it's an adjunct, you can use it as an adjunct to work out how much of treatment we need to provide, because whatever it is, some of this can be within, you can have a problem, but it may not be a problem that requires treatment. So one of the things we need to do is to work out what the impact of quality of life, like what the impact on their quality of life is. So definitely we need to work that out. And certainly looking for signs of anemia is a good indicator, because if the only reason somebody's anemic is because they're bleeding heavily during a menstrual cycle, then that tells us straight away that there is a problem here. So either you can use both subjective sort of symptoms for anemia and objective sort of measurement of hemoglobin. So that's one thing you can do. You can ask in the history whether the period is whether they're changing a pad, like a fully soaked pad, more frequently than every 2 hours. Whether they're waking up at night to change their sanitary towel because it's getting soaked or it's leaking. Whether the clots that they're having is larger than a quarter, like a size of a quarter. And you also, have to put that into context with duration, because you could have heavy menstrual bleeding, or you could have like reasonable bleeding, but it lasts for more than 7 days, in which case, again, it will be a problem that will lead to anemia. So history will help us there. But there are also things that you can send a patient away. So if you have a patient you're not really sure, you can sort of use something called as a pictorial blood loss calculator to help evaluate. So it is a semi sort of quantitative sort of evaluation method, because obviously you could never be 100% accurate when a patient is reporting something. You're not actually physically seeing the pads. You're not like doing any tests on the pads. You're sending people away with a tool for them to record what's happening to them at home, and then you can use that to evaluate if there's a problem or not. All right. Again, the sanitary towels that people use are not standardized. So whilst this is a great tool and it certainly is used in clinical practice, you have to keep in mind where the limitations of this tool is. So I'm going to talk you through this tool now. So this is called a pictorial blood loss assessment chart. It was developed in the 1990s and it's been validated since then. So it is an excellent tool to use. So has anybody used this before? Anyone? No. No. Sorry?
I think I've seen it somewhere, but I've not used it. Like easier visions.
So I'm going to talk you through how you use it. Okay, if I can make a point about. Okay, cool. So you give this chart. I've cropped the chart. So I've only cropped it till 5 days, but actually the chart goes on for like the whole like 28 or how many ever days you want the chart to go on. It's just, a table. So, it's also helpful for us to track cycle, like what happens in the cycle, because heavy bleeding only during the period is not the only thing we're interested in. We want to know if it's between period they're having bleeding as well. So it's a good way for people to use this as a menstrual diary as well. So what they have to do is, let's say date, you put your date here. This is the first day of the start of the period. They have to make an indicator as to how many heavy pads they had they changed during the day. So let's say this lady says she's changed 3 pads during the day. And then she also had sort of 250p sized clots. So then you sort of calculate with the point system. Yeah. And then you write down the score over here. Yeah. And so then she just has to do exactly that for all of the other days. She indicates with like lines as to how many pads or whatever she changed. And then you write all the scores here. And then finally, at the end of it, at the end of the menstrual cycle, you have a number. You'll get a number because you see each pad has a score and then you get a number. And that number will automatically correspond to the number of mils. So very easily you can sort of work out if it's over that 80 mil mark that we've made for ourselves as to call it normal. Does that make sense? Don't ask me to do the math of all the lines that I drew, which is why I drew the circles, because I'm not that good at math. So yeah. Okay. So then what happens is that obviously they had to evaluate to see if this thing is working or not. How sensitive or specific is this? Is this a good tool for us to use? So what this paper, so all of my references for everything that I'm quoting or saying is at it's somewhere on the slide. So you can see there's a systematic review that was done. And they looked at all the papers where a pictorial blood loss assessment chart was used to see if this is actually a good tool to use or not. Does anybody know what this statistic measure is? Do you know what this chart is trying to say? Can somebody describe it to me?
I'm not sure I can describe it fully, but the first thing that came to my mind was what's the area under the curve?
Exactly. So this is it's called a ROC curve. Okay, so it's a receiver operating characteristic. So if you were to sort of draw a line here, this is making a sort of curve. So I'm going to talk you through it. So you've got sensitivity on one side. And what you have on this side is 1 minus specificity, which means that this is the probability of you getting a false positive rate. Okay, so the further along on this x-axis you are, the worse the test is. So ideally, you want and perfect, like 100% sensitive, 100% specific test will find itself up here. So it'll be really high on the sensitivity, and it'll be low on the false positive rate. Okay, the worse the test is, if you draw like a line like that, it'll all be along this line. Okay, where it's neither great for sensitivity nor is it great for specificity. So this is like the worst place to be. So you can see how most of the tests fall under a pretty decent, most of the studies seem to indicate that this is not the worst tool you can use to assess your blood loss. Okay, obviously you have a big sort of variation because these were not like studies that followed the exact methodology. It was not like all of the pads were like specified, as to what they used. And so therefore, there is a big variation in how the studies have presented their results. But essentially, by looking at this curve, we can be assured that if we were to use this pictorial blood loss assessment, most likely we're getting the truth out of the patient. Yeah. So sensitivity ranges from 58% to 98%, specificity from up to 97% on a good day. Does that make sense?
Yes,
Yeah?
it does.
Okay. Any questions for me so far? No. Okay. So let's move on. Right. So now we come to the bit which gave me great grief whilst I was growing up. So how I was going to understand and remember these terms. And what I've concluded is that you just need to know two things. You need to know whether it's a bleeding problem or if it's a cycle frequency or regularity problem, or it's both. And I've also made it easy for you by highlighting the bits that actually we most commonly use. Okay, so menorrhagia means heavy or prolonged bleeding, but the cycle frequency is regular. So the woman will have like something that falls within normality in terms of cycle length, does not have intermenstrual bleeding. So essentially has a heavy prolonged bleeding, but otherwise cycle is fine. What does that tell us about that cycle? If you have a patient who presents with this picture where she says, oh, I've been having I've been changing a pad every hour. There's lots of clots. I'm anemic, and my bleeding is like for 7 days or more than 7 days, but I have 31-day cycles. What does that tell you about that woman's menstrual cycle?
Sorry?
Sorry?
Does it say that they're ovulatory cycle?
Exactly. So likely that the cycle is ovulatory. You will not get a regular menstrual period if there's no ovulation. So immediately with just understanding where on the table this person lies, you have some idea about the pathophysiology of what's going on. And that's why I think getting rid of the terminology completely is not very helpful, because actually it gives us a clue as to what's going on. And it sort of like helps us build this picture about where we need to target our investigations and what sort of management we need to offer her. Now, metrorrhagia, which actually you can forget the term, because what it means is intermenstrual bleeding. You've got some sort of like usually light bleeding between having two, between two sort of proper menstrual cycles. So as a menstruation. So you've got like what you know for sure is a menstrual period, and then you've got like light bleeding in between. So you know that that is intermenstrual bleeding. And so that's metrorrhagia. Now, if you have heavy bleeding, and even the intermenstrual bleeding part of it is heavy, then it's called menometrorrhagia. And the problem with this is that you don't know what is the normal menstruation as a menstrual period, and you don't know what is the intermenstrual bleeding because it's always heavy. So what sort of history will this person present with? What sort of history will this patient tell us if she's having menometrorrhagia? Anyone? I mean, I already explained it, so it's not that difficult. So essentially, you will see patients who will say that, oh, I've been constantly bleeding now for the last 4 months. I just have, maybe I'll have a day or two of like a gap, and then I will be back to bleeding, and it's constant all the time. So they sort of tend to fall under this category. All right, and people who usually present with this, the investigations need to be targeted more sort of like endocrine related investigations. It could be that they're having anovulatory cycles. So the pathophysiology behind having irregular, constant, not constant, but like on and off irregular bleeding is very different to somebody who presents with menorrhagia. Polymenorrhea is having normal periods, like normal bleeding, but having very frequent cycles, less than 21-day cycles. So that's polymenorrhea. Again, it could be ovulatory. So it could be that their proliferative phase is very short, and that's why they're having polymenorrhea. Polymenorrhagia is pretty much the same, very frequent cycles, but they have heavy bleeding during the time when they do have the period. Oligomenorrhea is normal bleeding, but very long cycles. What is the condition, most common condition that gives? Oh, yes, Jennifer.
Can I just ask, sometimes I see women and they say, I have periods, and they're like, sometimes they're 21 days in between, sometimes 25 days, sometimes 29. Does that still class as a regular period, even though there's a variation, like they don't have a definite 28-day, for example, cycle every month, but it's still within the sort of normal frequency?
So what you can do for them is to in order to work out the difference between regular and irregular, what would benefit them is to keep a menstrual diary. So it doesn't have to be the pictorial. If heavy bleeding is not their problem, you don't need to give them the pictorial sort of chart. What you do is mark on their calendar when they get the period, like for maybe a 3 or a 4 month time period, for you to work out whether this is just minor variation in the cycle length, or is it really irregular period where they just have no clue as to what's going on? Is that helpful?
Yeah, thank you.
Yeah.
Sorry, can I ask?
Yes.
You know, when you endocrine testing for menometrorrhagia, is that like TFTs? What else would you do?
Yeah, so I've got a whole thing about diagnostics. So I will talk you through. So terminology is just one part of the puzzle. You need to understand a bit about the pathophysiology, and I call it pathophysiology and not pathology, because when you get to sort of close to menopause, when you have premenopause, which is still within the reproductive age, you can have lots of changes in your cycle, which need not be pathology. It might just be that's part of physiology, and not all of that will need to be treated. So we will talk about pathophysiology, and then once you've understood these two concepts, understanding what diagnostic testing you need to do is very easy. Right? Oligomenorrhea is having very long cycles, infrequent cycles. Most common reason for that is anovulation and is commonly seen with PCOS. Then hypomenorrhea just means light bleeding. Again, can be, a part of perimenopause. For some women, they have regular cycles, but their bleeding just gets lighter and lighter. May not require treatment. But for some women, especially like, sometimes in some cultures, having a regular menstrual cycle with like adequate bleeding is considered healthy. And so for some women, it freaks them out when their periods get very light. So that's the reason you need to be aware that some women do have very light bleeding, and it can bother them. Is this clear enough? Is there anything you want me to explain a bit more?
No, thank you.
So then FIGO. So FIGO doesn't like the terminology bit, but it is really useful to understand how you can describe cycles. What FIGO would like us to do, and FIGO has, when they met and they sort of decided what they wanted to do with abnormal uterine bleeding, they published a paper. So you can have a look at the paper because I'm only going to talk you through a part of it. There's a lot more. You can sort of do a deep dive into each of these things, and the paper sort of goes into that. So you can have a look at that reference. But what FIGO would like us to think about is all of the reasons why somebody could have abnormal uterine bleeding. And they've obviously come up with a mnemonic for us to remember it. So palm coin is the mnemonic. Is this something people are familiar with, or is this the first time you've ever heard of it?
Heard of it.
Sorry? Familiar, did you say?
Yeah.
Okay, good. So essentially, this will help us understand why people could have the way we, describe the cycles the way they, usually describe it. So a polyp is, as you know, is a growth in the endometrium. With a polyp, like say the cause for abnormal uterine bleeding is a polyp, they can present generally with either heavy menstrual bleeding. The reason why people have heavy menstrual bleeding with a polyp is because it increases the surface area of your endometrium. So the bleeding surface is larger than if you didn't have a polyp. So heavy menstrual bleeding, which can be prolonged. But also the other sort of pattern people will present with is having intermenstrual bleeding. So having spotting in between periods. And if somebody presents with spotting in between periods, your first set of differential diagnosis should be polyp. All right. And when you're talking to somebody, when you're taking a history from somebody and you're examining them, what you also need to think about, not only how do you describe what they're telling you in medical terms using terminology, but also about what could possibly be the reason, because your diagnostics and your treatment options will be tailored to what you think is a differential diagnosis. So if it's heavy bleeding or intermenstrual bleeding or a combination of the two, then you think polyp. Okay. Then adenomyosis is, I'm sure all of you are familiar with what adenomyosis is. It's a sort of form of endometriosis where the endometrium has grown into the myometrial sort of layer of the uterus. What they will present with is heavy menstrual bleeding, usually, but also accompanied with pain. So obviously you need to ask a bit about the dysmenorrhea. So that's how they will present. Again, will help us, you will diagnose this using either ultrasound or MRI. So each of this will have a different diagnostic test. For polyp, you can diagnose a polyp using ultrasound. If ultrasound is not very clear, you can use something called a saline infusion sonography, where you inject some saline into the uterus and you scan with an ultrasound, and that will help us delineate what's going on in the endometrium for the polyp. And obviously, hysteroscopy would ultimately be a therapeutic step to take for a polyp. For adenomyosis, it's ultrasound, and if ultrasound is not very clear, you could do an MRI. Does anybody have a question? I can hear the mic going off. No?
No.
Okay. The next differential diagnosis for abnormal uterine bleeding is fibroids. Now, obviously, you know that fibroids are really common. 80% of Afro-Caribbean women have fibroids. Most of them are asymptomatic. But what FIGO has done is they've subclassified. So the type of fibroid that causes abnormal uterine bleeding is submucosal usually, or sometimes intramural that's impinging into the cavity. So what you should do is to look up this paper, because they have reclassified, they have given you a separate classification about submucosal fibroids and how to sort of grade them. Which is useful, especially if you go on to become really interested in hysteroscopy. Then it's useful to understand how FIGO has classified fibroids further, depending on the location of the fibroid. But if you think that the reason why somebody is having abnormal uterine bleeding is fibroid, you can diagnose it with an ultrasound. Again, an MRI as well, if you're really not sure about what's going on. But ultimately, if it is a submucosal fibroid, you should be able to see it on a hysteroscopy and hopefully treat it through hysteroscopy as well. Yeah. And then to finish off PALM, the last one is malignancy and hyperplasia. Now, there will be lots of things within the history itself that will help us think about hyperplasia. So usually it's overweight women who've had a history of anovulatory sort of cycles, very sort of long cycles, and then heavy bleeding because it's anovulatory. And could have like diabetes and metabolic disorders. From the history itself, you sort of think, oh, could this be hyperplasia? When you do a scan, because we're talking specifically about reproductive age of women, your cutoffs that you use for postmenopausal bleeding is not valid over here. So a scan is useful in order to sort of, an ultrasound scan is useful in order for us to sort of work out if there's anything else that's going on. But ultimately, you need a tissue biopsy in order to diagnose hyperplasia/malignancy. So you can either do that with a Pipel, but the pickup rate with the Pipel is not all that good. So ultimately, hysteroscopy, visualization of the endometrial cavity, and a targeted biopsy would be the best way to do that. Now, the coin part of it is sort of endocrine related causes for abnormal uterine bleeding, or systemic reasons for abnormal uterine bleeding. So coagulopathy. Now, coagulopathy is something that you need to suspect when you have somebody of pediatric age group. So if you've got by pediatric, I mean like teenagers. If you have somebody who's just started to menstruate, and ever since she started to menstruate has been having menorrhagia, then one of your differential diagnoses, apart from anovulatory cycles, which again is common in teenagers, is coagulopathy. 13% of women who present with abnormal uterine bleeding will have a recognized coagulation disorder. So it's not that it's super uncommon. The most common coagulopathy is von Willebrand's disease. It could also be that she already has a diagnosis and she's come to you just for management of heavy menstrual bleeding. That's one way people can present as well. Is that clear so far?
Yeah.
Yeah. So then the O in COIN is for ovulatory dysfunction. And this is where the whole sort of like anovulatory cycle bit of it falls into in the palm coin classification. All right. So it can affect both regularity, because if you don't have ovulation, you don't have the fixed luteal phase of the cycle, then you don't have menstruation that is going to start in a regular way. So you'll have periods where the proliferative phase is so long that the endometrium has overgrown. And then you will have this heavy bleeding, uncontrolled heavy bleeding, because the endometrium is not able to support itself. And without that sort of luteal progesterone effect on the endometrium, the mechanisms to turn off menstruation is also not present. So the prostaglandins haven't kicked into place. Then you don't have the sort of restart of the proliferative phase once bleeding has started. So it completely messes up the whole sort of cycle. So you'll have like prolonged phases of amenorrhea, followed by prolonged bleeding, which will not sort of stop easily with just giving tranexamic acid and things like that. So that's how anovulatory cycles and heavy bleeding will present. But you need to also think about other endocrine reasons, because they all have they all have a role to play on ovulatory function. So you need to think about prolactin, thyroid. Okay, so those are the two sort of endocrine tests you'll be doing. But also think about history that will help you narrow down which direction you need to go in. So weight gain, having sort of anorexia, over-exercising, stress, all of them will sort of suppress your hypothalamic function. So again, can present with abnormal menstrual bleeding, but may not, require any medication for you to treat. So in ovulatory dysfunction, you'll think about anovulatory cycles, most commonly because of PCOS. You'll think about prolactin, thyroid, and physiological things that can mess up the menstrual cycle. All right? So far, so good? Okay, great. So then you come to the endometrial reasons why you can have abnormal bleeding. Okay, so this could just be infections, like chlamydia can give rise to sort of abnormal bleeding. You can have like intermenstrual like spotting, because chlamydia affects the endometrial sort of vascular genesis, and prostaglandin sort of like production on the endometrium is messed up by a chlamydia infection. So infection is something you need to keep in mind. But also, like people can have vascular issues with the endometrium. Vascular genesis can be affected. There can be AV like malformations within the endometrium, which can give rise to heavy menstrual bleeding. So that's something to keep in mind as well. Usually, you diagnose it by doing an ultrasound. So usually, you'll pick up anything really like if it is like endometrium is usually you will see some sort of vascularity within the endometrium if you do an ultrasound. And obviously for chlamydia, you do a swab, and that's how you pick that up. All right. Generally, endometrial disorders are diagnosed by excluding everything else. But it's something to keep in mind. And then the iatrogenic bit is important. So when we take the history, we need to think about all of the other medication that she could be on. So if somebody's depressed and is on tricyclic antidepressants, that reduces the inhibition on prolactin hormone and can give rise to amenorrhea and messes up the HPO axis. They can be on blood thinning medication. Sometimes what happens is that people don't disclose. They don't consider contraception as medication. So when you ask about, are you on any medication, they don't disclose that actually they're on contraception, because that's just, people don't think of it that way. So you need to specifically ask about contraception, because when you give an progesterone only contraception, what happens in the first 6 months of progesterone only contraception, whatever the form may be, Mirena or implant or depot injection, what can you expect in the first 6 months? Sorry?
They're whispering irregular bleeding.
Yeah, so what you have to prepare the patient for, so this is part of counseling for contraception. What you need to prepare the patients for is that for 6 months, they can have, they may not get a proper period. It might just be that they bleed a little bit every day. Different people react differently. People could have like regular periods, but have intermenstrual spotting in between. And usually take 6 months of being on a progesterone-only contraception before things settle down. And the importance of like helping them understand that is so that they don't keep changing contraception every month. Otherwise, people will be coming back saying, "Oh, this is not working," and they shop various contraceptive methods. And B, that then they're not surprised by what they find, so that they are mentally prepared that this is what they're going to experience whilst they're on that contraception. Now, the other problem you can have is somebody who's on combined oral contraceptives, and either they've missed a dose, or their dose is very low for them, and then they can have like spotting, apart from the withdrawal bleeding that they have. So again, history taking is important to determine what exactly your treatment or your investigation methodology is going to be. And obviously they have, FIGO has decided to put not yet classified in order to finish the coin. Otherwise it will sound really weird, PALM-CO. And also because they have to, have some way to classify things that come up in the future. So not yet classified. I don't know what belongs there, but they have that on the classification. Okay, so we have now reached the pillars of our building. Are we clear about how we got there? We've understood our foundation, and then we understand how terminology and pathophysiology sit next to each other. Yeah. Okay, am I doing okay for time? Probably not, but anyway, let's keep moving on. So then what FIGO wants us to then do in order to manage the situation, now that we've understood what possibly could be the issues, they want us to think about abnormal uterine bleeding as acute and chronic. Obviously, acute bleeding is actually acute on chronic because they have chronic menorrhagia and then they come present with this acute episode of, completely like flooding. And that's what is acute abnormal uterine bleeding. And they've given us definitions for it. Now, what FIGO have done is in this definition for chronic AUB, they've said 6 months of having abnormal volume, regularity, timing, bleeding. But when they come to the management, they've used 3 months as their cutoff. So I suppose they've left it to the clinicians to decide when to intervene and treat. So when it's acute, it's very easy. I think all of us do it anyway on a day-to-day basis on a gynae on call. You, if they've come in with flooding and they're, you check if they're anemic, you do all of the bits that you do for initial assessment, like history and examination, check the observations, have IV access, you cross-match, check hemoglobin. If need, you can transfuse. IV fluids if they're really in shock. And a blood transfusion essentially to correct the anemia that you have diagnosed. In order to stop the bleeding, primarily it's medication. So use tranexamic acid and progesterone therapy are the 2 ways to stop the bleeding. Most of the times it's this sort of bleeding is because of the lack of ovulation and not enough progesterone ripening the endometrium. So therefore you need to give the progesterone therapy in order to stop the bleeding. And then part of it is then after you've sort of gone past that acute stage and things have stabilized, then you need to talk about long-term therapy to prevent, which we will talk about in chronic chronic AUB anyway, but essentially it's to give some sort of a hormonal contraception or progesterone therapy, either Mirena or progesterone only pill or COCP. And then if they've tried that and that hasn't worked in the past, then there's ablation, endometrial ablation or hysterectomy, depending on what they want to do. So that's as far as acute AUB is concerned. And this should not be new to anyone because this is what we do on a gynae on call anyway. Is it okay for me to move on? Yeah. So then when it comes to chronic abnormal uterine bleeding, this is the flow charts that the FIGO have suggested we use. So essentially you first of all work out if they're having abnormal uterine bleeding and if it is chronic. And if it is, then you do a history because it'll, as part of the history, you need to work out if they want fertility or not, because obviously your treatment options will then have to be tailored, because if they're planning to get pregnant, you can't put them on oral contraception or like suggest endometrial ablation or any of the things. So you need to work out whether fertility is a concern for them. Also, with the history, narrow down what could possibly be causative, could be the reason for abnormal uterine bleeding. So if you think that it is systemic, you might have to involve a hematologist. If you think it's like coagulopathy, or if you think it's endocrine, then you might have to involve, medical, like the medical team or whatever it is. So you determine where the problem is. Then in the physical examination, if you think it's because of some sort of organic cause from the uterus itself, then we will talk about what uterine evaluation we need to do. Obviously, alongside, you need to check if they're anemic and correct that as well, and check thyroid function, prolactin, or whatever it is. So for uterine evaluation, if we think that the abnormality lies with the ovaries of like organic cause within the ovaries or the uterus itself, if we think this is a hyperplasia, or if we think she falls under that sort of AUBM category, then we need to take a biopsy, which could either be hysteroscopic guided, or it can be a Pipelle biopsy. And then that's pretty straightforward to diagnose. And the management, again, will follow the path of the guideline for hyperplasia, which is depending on the type of hyperplasia, you give them progesterone or you do a hysterectomy. If you don't think it's in that criteria, then you have to essentially do a TV scan. And if the cavity is normal, then you think, is it endocrine or is it, anovulation? If the cavity is abnormal, you do a hysteroscopy and you treat. And if you think that SIS stands for saline infusion sonography, which is what I was talking to you about, it's really, really good at helping us differentiate polyps in the uterine cavity without subjecting them to a hysteroscopy. So it's got a very high specificity for that. but obviously not everywhere does it. But that's something to keep in mind. And obviously, treatment is very easy. If you find something abnormal like a polyp, you can do a hysteroscopy and get rid of it. And if you can't work out what's going on, you can consider doing an MRI. Is that okay? So far, so good? Yeah? Okay. I'm going to move on. Now, this is a questionnaire that you can use to decide if a pediatric patient or if somebody you suspect has coagulopathy, if they fit within that criteria. So as you can see, it very clearly relies on history. And about heavy menstrual bleeding and about having bleeding in surgical settings, like in a hospital setting, like with dental work or when they've had a surgery and they can't explain why there's been bleeding. And also, coagulopathy related bleeding where you've got bruising and gum bleeding and family history. So if they score high enough, then you should refer to a hematologist and get tested for coagulopathy. And finally, once you have determined what the problem is, then you can manage chronic AUB. The things that you need to take into consideration is it affecting? So somebody said about quality of life, that's the most important thing. Do they want treatment for it? Is it something that's affecting their quality of life? And how much do they want? How interventional do they want you to be? And medical history, because some of the things you can't offer to everybody. So medical first line therapy, and this is based on the NICE guidance for heavy menstrual bleeding. First line is giving Mirena. Obviously, if there is a fibroid that is more than 3 centimeters in the uterine cavity, this is not the right option because you can't fit the Mirena properly. But this is the first line. It is off-license use of Mirena, so we need to talk about that because Mirena is only licensed for contraception for 5 years. So this is off-license use. And you need to if you've not done a biopsy of the endometrium, you need to be sure that you're not suspecting anything before you put a Mirena in. Non-hormonal, if they want to get pregnant, then non-hormonal options are TXA and mefenamic acid if there's also pain sort of involved with heavy bleeding. Hormonal, if they don't want a Mirena put in, then hormonal options are combined oral contraceptives and oral, the progesterone-only pill. Now, if your scan has said to you that actually you've got a fibroid that's more than 3 centimeters, you can pretty much offer all of the above except the Mirena. But even the Mirena you can offer if you manage to resect the fibroid hysteroscopically, then you can put a Mirena in. But you could also, I don't know if you've heard about ulipristal acetate, but that's a medication that we can use. And I've got a slide on that, so I'll talk you through what that means. But that's a good option for people as well, as long as they're counseled about the risks. Now, if they've tried medical management and they're not entirely sort of happy with it, then you can consider sort of surgical procedures. And surgical procedures are from minimally invasive to obviously, finally doing a hysterectomy. So minimally invasive procedures is uterine artery embolization, especially if it's useful for people who have a large fibroid. And doing a myomectomy if you think that the reason why they are having heavy bleeding is because of the fibroid. So that's 2 options that's available for people with fibroids. You can offer an endometrial ablation for people who have a smooth cavity, so no fibroid, but want a sort of permanent solution without having to use medication. So endometrial ablation, and you can use NovaSure or even NovaSure is what is suggested by NICE guidelines, but obviously some hospitals don't do NovaSure, so then you'll have to rely on endometrial resection. And then you've got hysterectomy finally if all of your other methods have failed or if after counseling that's the only thing that the patient wants. Is that clear? Yeah. So ulipristal is essentially for people who are premenopausal, who have heavy bleeding and have a fibroid that's more than 3 centimeters in diameter. And particularly if they're anemic as well, and if they don't want any of the other choices or they don't are not fit for any of the other choices, then you would suggest ulipristal. The problem with ulipristal is that it has been associated with liver injury, so which is why they need monitoring. So once you start them on treatment, they need to have monthly blood tests done for the first 2 sort of cycles, and then After that, you'll have to infrequently monitor like liver function tests. So it's 5 milligrams daily for up to four cycles, menstrual cycles or whatever it is. So that's what you need to do with ulipristal. And then if you think that there's liver dysfunction, you have to test and stop the medication. And lots of the times it reverses, but obviously there have been reports of permanent liver injury as well. So that's to keep that in mind. And I think we're nearly at the end. So I hope we have come to a point where all of this we have covered. You've laid the foundation. You've understood how terminology and pathophysiology sit next to each other. And then you've understood about how to approach using history, examination, and investigations, and then finally manage according to what symptoms are there. Is there any questions at all?
I have a question. Crystal asked, is that just sort of like a holding measure, or is it that the 4 courses will have like a lasting effect?
So it can shrink the fibroid. So it may have a lasting effect, especially if the fibroid is really big, and you can use it as a method pre-surgery if they're waiting for a surgical appointment to make your operation easier. So initially when we introduced ulipristal, that's what we were using it for. But I've also seen it being used for cases where they're not fit for surgery, and they've not had any problems with ulipristal, so they just continue it for a bit longer with it, just to manage it as well. And sometimes that is enough to shrink the fibroid, enough to make their symptoms manageable.
And when you say like a course, is that just during their monthly bleed?
Yeah, so you take a course as what you would consider a normal period. So essentially 4 months is 4 courses. Yeah. And finally, I wanted to leave you with this picture, which I've taken off one of the sort of influencers on Facebook who talks a lot about like menstrual health. It's to remember that the patients we treat and we see have an entire life to manage other than having heavy periods. So it's to sort of be kind to them and to sort of keep them in mind when we talk to them about treatment options. Any questions at all? I think I've managed to just about finish on time.
That's brilliant. Thank you, Aditi.
Aditi, did they not amend the
Sorry?
nice HM? Did they not amend the guideline for ulipristal recently in 2021?
I don't know. I got this off like nice guidance. So yeah, I don't know if they've amended that separately or if the manufacturers have come up with something different.
But they had stopped last year. They had put a hold on
They had
using.
initially stopped it because the liver dysfunction was thing, but I think it's come back now because they've not taken it off the guidelines.
But you don't find many people using it for that reason, because it affects liver function. Thank you. So any comments from anybody online for Aditi, comments or questions?
I did want to speak to everybody about this research thing that I'm doing that I will hopefully be able to contact you about soon enough. There is